Hello, my name is Lisa Doyle, and I am presenting my Doctor of Nursing Practice Quality Improvement Project, implementing the Walking Impairment Questionnaire for Peripheral Artery Disease Screening and Referral. I will briefly discuss the clinical problem, the intervention, project implementation, findings, and recommendations for future practice. Peripheral artery disease is the third leading cause of cardiovascular death, yet many patients are not identified until the disease is advanced. This project evaluated whether implementing the Walking Impairment Questionnaire could improve identification of symptomatic veterans and facilitate timely referral to supervised exercise therapy. Like this canyon, a wide gap separated evidence-based care from clinical practice. Although supervised exercise therapy was available, only 4 veterans completed the program in 1 year. Workflow analysis showed that inconsistent screening and referral practices prevented many veterans from reaching appropriate treatment. Peripheral artery disease affects up to 21 million Americans and is especially common among veterans. Delayed diagnosis contributes to disability, reduced quality of life, amputation, and increased healthcare costs, highlighting the importance of early identification. The aim of this project was to enhance the screening and referral process for supervised exercise therapy by integrating the Walking Impairment Questionnaire into the nursing workflow. By replacing inconsistent provider-driven screening with a standardized process, the project sought to improve identification of eligible veterans. National guidelines recommend supervised exercise therapy as first-line treatment for symptomatic peripheral artery disease. However, before this project, referrals depended almost entirely on provider assessment without a standardized screening process. The evidence supported the WIC as a valid and reliable patient-reported outcome measure for assessing functional limitations in patients with PAD. Studies showed that WIC scores correlate with walking performance tests and can help identify functional impairment when traditional testing is not feasible. This supported using the WIC as a practical screening tool. 2 frameworks guided implementation. Plan, Do, Study, Act cycles allowed us to test and refine workflow changes, while the Ohio Health Change Management Model focused on stakeholder engagement, communication, education, and sustainability throughout the project. This quality improvement project was implemented over 12 weeks. Activities included tool development, staff education, screening, workflow refinement through PDSA cycles, data collection, analysis, and dissemination of findings to organizational stakeholders. Over the course of the implementation period, this project transformed the vascular nurse's role from supporting clinic flow to leading standardized PAD screening. The nurse administered the questionnaire, calculated the score, documented the results, and communicated positive screenings during the pre-clinic huddle to support timely clinical decision-making. The primary outcome measured whether eligible veterans access supervised exercise therapy within 28 days of referral. 1 veteran met this goal, while the second declined participation because of financial concerns. This finding highlighted that patient-level barriers can influence outcomes even when the referral process is successful. Screening compliance exceeded expectations. More than 100% of eligible encounters were screened because 2 veterans completed the questionnaire twice after rescheduling appointments. This demonstrated successful integration of the Walking Impairment Questionnaire into routine nursing workflow. Documentation represented one of the project's greatest challenges. Required documentation supporting supervised exercise therapy eligibility and patient education was frequently incomplete, limiting both implementation fidelity and the opportunity for third-party reimbursement. Although provider documentation of treatment recommendations was low, every patient who was clinically appropriate for supervised exercise therapy received a referral. This demonstrated that clinical decision-making remained appropriate despite documentation deficiencies. Perhaps the most important finding was unexpected. Most veterans with positive screening results already required surgery or other advanced vascular interventions. The screening tool worked, but it was being used too late to increase supervised exercise therapy participation. These findings suggest that the greatest opportunity for improving outcomes lies not in the screening tool itself, but in screening patients sooner. Earlier identification may increase participation in supervised exercise therapy, preserve mobility and quality of life, and reduce progression to advanced peripheral artery disease. Rather than waiting until patients reach vascular surgery, this Veterans Hospital should integrate the Walking Impairment Questionnaire into earlier points of care, such as the primary care setting. Earlier screening has the potential to increase access to exercise therapy, preserve mobility, improve quality of life, and slow disease progression. Successful implementation required more than just a new screening tool. Provider engagement, structured interdisciplinary huddles, and consistent documentation were essential to sustaining practice change and achieving implementation fidelity. This project demonstrated that standardized screening is feasible and highlighted opportunities to improve access to care, strengthen interdisciplinary collaboration, and support quality improvement consistent with the triple aim and the AACN DNP essentials. 3 lessons emerged from this project. Standardized screening is feasible, earlier identification is critical, and successful implementation depends on communication, provider engagement, and interdisciplinary collaboration.